Good afternoon, and welcome to RPA's webinar on pathways to improve nephrologist comfort with self-care dialysis in center and at home. I'm Desiree Bryant, RPA's Director of Meetings. Thank you for joining us. During the webinar, all lines will be in listen-only mode. There will be a Q&A session at the end of the presentation. You may submit your questions at any time using the Q&A feature, which is located at the top of your screen. You should also see an emoji button that you can use to let us know your thoughts on something mentioned during the presentation. So let's practice. Give me a thumbs up if you see the Q&A feature at the top of your screen. Excellent. We already have participation, so that's great. Please do not submit questions in the chat. Please use the Q&A feature only. If they're in the chat, they may not be captured or answered. CME and nursing education credit are available for this webinar. After the webinar, you will receive an email from me with instructions on how to claim your credit. Finally, this webinar is being recorded and will be made available in our e-learning platform. Now for what you all have come here for. RPA is very pleased to have Dr. Tushar Chopra as our presenter today. Dr. Chopra is the Medical Director of the University of Virginia Dialysis Unit in Appomattox, Virginia, and is also an Assistant Professor of Medicine in the Division of Nephrology at the University of Virginia Health System. He serves on the National Kidney Foundation of Virginia's Medical Advisory Board and is a member of the Mid-Atlantic Renal Coalition ESRD Network 5 Medical Review Board. His interest includes providing personalized care to patients with kidney disease and overcoming barriers to uptake of home dialysis modalities. Dr. Chopra, the mic is yours.
Thank you, Desiree, and thank you everyone for taking time off on a Thursday afternoon. I know everyone is busy. I would also like to thank RPA for this opportunity and timely webinar with the recent release of the payment models regarding home dialysis and payment structures. I hope I'm audible enough, and if I need to change anything, do let us know through the chat function, and we will take questions in the end. These are my conflict of interest, which is I'm a part of the Medical Review Board for Network 5, and I'm also part of the Medical Advisory Board for National Kidney Foundation Virginia chapter. These are the objectives of my talk. I'm going to try and divide the talk into a few parts. Initially, we will talk about home dialysis as a viable option during the COVID-19 era. What are the clinical considerations we may have in remodeling dialysis delivery, especially in-center self-care dialysis? What kind of business operations, clinical considerations we need to keep in account? And then I would change from remodeling dialysis delivery to the challenges that we have in uptake of home hemodialysis. And lastly, how we can have more patient and care partner empowerment and engagement strategies for home hemodialysis. We all are aware a year ago, that was July 10th, 2019, there was an advancing American Kidney Health Initiative which set the goal of 80% of incident end-stage renal disease patients to start a home dialysis modality or receive a kidney transplant by 2025. There are certain other parts, other three goals of the American Advancing Kidney Initiative, ensuring that we reduce the number of Americans developing kidney failure by 25% by 2030, and doubling the number of kidneys available for transplant by 2030. What I have shown here is a hub and spoke model where the goal is in the hub, and there are these different spokes which I have outlined over here, and every organization is probably going to develop their own spokes in trying to achieve these goals. These are just what we've been working on, which is education of patients, education of nephrologists. We're trying to conserve residual renal function as much as possible for good outcomes. Adopting innovative technology, not just in dialysis machines, in PD fluid, in having remote data monitoring to try and keep patients outside the hospitals with cyclotherapies. We all have probably adopted telehealth by now because of the COVID-19 era. And here we have a little bit of remodeling transition dialysis delivery with transitional start units, graded self-care units. We could do urgent start PD or assist PD. Now, the emphasis of remodeling of dialysis delivery is taking the focus away from in-center, and that's why there is nursing home PD and various other avenues of remodeling delivery that we can focus on. So I'll try to summarize at least the remodeling delivery part and the home hemodialysis part during this talk. We won't be talking about everything else. Now, what are the viewpoints of the patients and the caregivers about end-stage renal disease treatment decision making? What do they think? When you ask somebody why they want to do peritoneal dialysis, they'll say, because I want to be self-sufficient, I want privacy, flexibility in my schedule. I don't want to travel a lot. This is great for rural areas. Lesser admissions. They have more time. Some of them are fearful of needles and don't want to do home hemodialysis. Or they are worried about the appearance of the fistula or cross infection. If you were to ask what interests people about dialysis, hemodialysis, like care from others, preferred planned schedule. I hope I'm audible. Am I audible enough? If I could get a thumbs up? All right, okay, good. Now I saw a chat message that they couldn't hear, so I just wanted to make sure. So the people who prefer hemodialysis are the ones who like to get care from others, are a more vulnerable group. They prefer a planned schedule or an assembly line atmosphere. They like their furlough days, that is the free days off, come 3 times a week and the rest of it is on you. They've had previous knowledge of in-center dialysis. They prefer swimming, so they cannot do other forms of home dialysis. Convenience. These were the viewpoints that patients have. What are the considerations that people have or the provider has when they're selecting a home dialysis modality? Lifestyle, informed choice and relationship. Quality of life is extremely important, and that is what matters most to the patient. It is very, very important to spend some time with our patients discussing their quality of life. What do they want from dialysis? Some may say we want to work. Some may say I want to achieve my familial milestones. I need to have a family. Some just want a kidney transplant. Some have social milestones. They want to go visit their grandparents or grandchildren in different states, and that's how they would like to spend their time. And some just want to feel better. It's important to understand the goal of the patient. For example, if it is a young patient who has just started incident dialysis, their goal ought to be a kidney transplant. And we must tell them that we will try our best to reach the kidney transplant goal, but in between we may have different forms of dialysis and modalities, and we may have to do each and every one of those, but we need to keep focus on the goal. It is also important to understand if they don't choose transplant as the goal. If a young patient is not choosing transplant as a goal, we need to inquire what's going on. Do you need any kind of social help? Is there something else that is preventing you from getting a kidney transplant? And luckily, we have social workers and a lot of support system in the in-center dialysis unit that can help us work through these goals that we set with our patient. So very, very important is that we discuss the quality of life with our patients. Well, I write over here that quality of life and length of life is not mutually exclusive. Survival, we will come to next, but not everybody is looking to live an extra, 10 days or 20 days when it comes to different dialysis modalities. In terms of survival, The bottom line is the survival, there are many registry data, propensity scored, matched. All of them keep showing the same results over and over again. That is, the survival of PD patients is improving over time, and the survival of hemodialysis patients is unchanged. So the survival between the two modalities is essentially the same. There are some medical benefits of choosing home dialysis therapies, like there is lower risk of dementia with peritoneal dialysis. There is equal hospitalization rates of infections in propensity matched pairs of hemodialysis versus peritoneal dialysis. And there could be economic reasons. The economic reasons would be a home dialysis patient, especially peritoneal dialysis, are more likely to be employed. We don't have data about the home hemo patients yet because they are so low, but these could be the considerations that we have before we discuss modalities with our patients. Either it's in clinic or you could have this discussion in the dialysis unit. I wanted to spend some time talking about these transitions during the continuum of chronic kidney disease patient and the opportunities for self-care dialysis that can happen. These transitions are going to happen in most patients. They will go from the pre-end stage renal disease era to dialysis, and once they do dialysis, they will switch around from hemodialysis to PD. They may do hybrid form, they will go on transplant, and they will come back. And ultimately, this could continue. After getting transplant, they come back to the doctor in a transplant clinic with good renal function. So I have tried to discuss these transition points in phases over here. It could be a gradual transition or an abrupt transition. Gradual transition means you have time to prepare. This is the CKD clinic where you can discuss education, you can prepare them for an access, you can talk about different modalities. There is a good chance if the patient has been educated and knows about all forms of modalities that they will choose home dialysis as a modality. You can also discuss how you're going to preserve residual renal function, which we'll come to next. But sometimes we don't have the luxury of seeing the patients very early. We have late referrals, and what always happens is these abrupt starts. The abrupt starts are the hospital starts, someone who's never seen a nephrologist, or this is a late referral, and or this is acute kidney injury in the hospital. Here we have certain expedited models like urgent start PD can happen, transitional start units can happen, and in order to have a smoother transition and provide education to the patient because they haven't had that in the pre-end stage renal disease era. Then we come to whether this is early versus late start dialysis and the initiation of dialysis, whether it is frequent or infrequent. Why do we discuss frequent versus infrequent is because we're trying to preserve residual renal function in the patient as much as possible. There are a lot of advantages of preserving residual renal function, which I'm sure everyone is aware of. In terms of modalities, I want to emphasize we must leverage all modalities over the lifetime of the patient. We must use all therapies if indicated and needed. But the most important thing is to do the right therapy at the right time. So here I have also written some strategies of incremental peritoneal dialysis that can happen if you're trying to preserve residual renal function. And in the bottom, I have listed transition points, which can be related to several factors like access not working, uncontrolled volume, cardiovascular complications, metabolic derangements, protein energy malnutrition that can lead to transitions. I'm going to also talk a little bit about transitional start units, but I'll talk a little late. But the novel transitional start units exist. They can offer smoother transition to hemodialysis or peritoneal dialysis, especially for the crash start patients. And these patient-focused transitional start units have been there since 1981, and they offer opportunities for incremental PD as well as home hemodialysis as the patient transitions in different renal replacement therapies. The common theme of transitional start units is that it is patient-centric approach through a dedicated team with a focus on education in different forms of dialysis to improve the care of an incident end-stage renal disease patient. This slide is important, and we must spend a little bit time on this, is factors affecting utilization of home dialysis. And every system needs to do some introspection as to what may be the rate limiting step in their environment. This is specifically for peritoneal dialysis because of my interest in peritoneal dialysis. And I want y'all to see the facility factors. The facility factors could be a clinician bias or attitude. If someone is not comfortable with home hemodialysis or peritoneal dialysis, they're less likely to put a patient on that. It could be PD catheter placement. For example, if you're in a rural setting, in a community hospital, and you have a practice there, uh, who is going to place the PD catheter? Are you going to have good outcomes in placement of the PD catheter? Is the catheter going to be placed in a timely manner? Is it going to be, are they going to wait 6 months for an appointment because there is only one vascular surgeon in the area? So these are rate limiting steps in goals of trying to improve outcomes for patients. We must introspect and figure out what is the problem in our system and try to address that. Of course, organizational priorities, and I know most organizations and large LDOs and smaller dialysis companies have aligned themselves with the White House in trying to provide all modalities of education and doing what is important for the patient. I've also outlined it could be PD fluid. There was, if you guys remember, there was a shortage of PD fluid that happened, which led to decrease in utilization of PD uptake, and we had to outsource. We had to get the fluid from Ireland, and only then the PD had improved. And like that, there are patient factors, and then there are health system factors. The health system factors are very, very important because it is usually the health system that has to support utilization of home dialysis uptake for anything to happen, like having a PD first policy or a PD preferred policy, incentivizing dialysis providers, patients, as well as physicians in the uptake of modalities. They all come from health system factors, and currently with the White House directive, we have that in place. So with that, we're going to have a poll question over here. So what has been the challenge in home dialysis or transplant uptake in your practice during the COVID-19 era? Access placement seems to be winning over here. Very good. I think we have all the results. So it seems like access placement is definitely a rate limiting step. And here I'm going to switch gears and talk a little bit about COVID-19 and how we are going to align ourselves with doing what is best for the patient. Why should we choose peritoneal dialysis during COVID-19? We know that peritoneal dialysis offers lots of advantages relative to conventional in-center hemodialysis. There is more autonomy to the patient. It's more patient-centric. They have independence, they're engaged in their therapy, they have better quality of life. They also have better preservation of residual renal function. It avoids the tunneled catheter and its concomitant complications. It's more cost effective. And during COVID-19, we must emphasize that if you did home dialysis therapies, you would be less exposed to the conventional in-center unit, and you wouldn't be getting out of your house and unnecessarily going to a high-risk area, which is any medical facility or a dialysis unit or a nursing home, and be more vulnerable to contracting COVID-19. So, uh, and these are important things to discuss with the patient, either in the PD clinic or in the dialysis unit, as we are doing education. Here, I have tried to summarize a little bit about the pathways that we could adopt to increase the comfort in managing a kidney disease patient during COVID-19. I'm glad that everyone said that they had access issues, but CMS has very clearly uh, uh, emphasize that access placement is essential. Access is the lifeline of the dialysis patient, and we must advocate as nurses or managers or doctors in trying to get their lifeline in place. And there should not be any delay in access placement or troubleshooting and access during the COVID-19 era. And I think if that is an issue, you may have to talk to the managers or the hospital or interventional radiology and clarify those. So in the pre-end stage renal disease era, we have all gone virtual. I'm sure everyone has virtual education classes. We used to have in-person classes, but now I think with the virtual platform, just like this, we're able to reach way more masses than we used to be able to do before. The catch with the virtual is try to have short videos of different modalities: peritoneal dialysis, home hemodialysis, transplant, conservative management, education, diet. Try to keep it short and not 1 hour and 2 hour longs, because the attention span may not be there for so long. We also discussed about access placement, but endovascular AV fistula, there are innovations in access placement. Some of our patients are high risk. They cannot undergo general anesthesia. We must have an innovative mindset and try to adopt endovascular AV fistula, which uses regional anesthesia. It can be done by interventional radiology. It can be done by interventional nephrology. It can be done by vascular surgeons. And they use ulnar artery, ulnar vein, the veins that are normally not used by PICC lines or IVs. So these are strategies that we can have in order to keep achieving the access goals. Hospital starts, I mentioned acute kidney injury on dialysis because COVID-19 is associated with AKI. Urgent start PD and home hemodialysis machines could be used to perform nocturnal dialysis, and I'll come more into this topic. And end-stage renal disease patients, we all are using telemedicine, but some may be using nursing home peritoneal dialysis, but that is an area that could be expanded on in trying to keep the nursing home patients in the nursing home, as they are a vulnerable group, and the hemodialysis patients can be dialyzed. They could be switched to peritoneal dialysis. They could be started on cycler. You could train nursing home nurses to do peritoneal dialysis for them so that they keep doing dialysis. You save on transport costs. So a little bit of clarification on the hospital starts. What can we do? Urgent start PD, you must have the personnel to place the PD catheter there and there in the room. The issue is the reimbursement for PD patient who is acute kidney injury is not yet covered. That is still with in-center, but that may change. Short daily hemodialysis, we do use home hemodialysis machines in AKI patients, especially if there is resource limitations, as it has happened in surge areas like Texas and New York. I try to use nocturnal hemodialysis. I use a home hemodialysis machine overnight so that during the day the patient can participate in physical therapy and get better. So these are strategies that one could use during the COVID-19 era. A little bit of urgent start PD. We all know that we can, these protocols involves initiation of PD in less than 2 weeks. It is low volume supine cycler peritoneal dialysis. It can happen in outpatient or inpatient. Treatment is 6 to 8 hours, either 3 times a week, 5 times a week. And the advantage of urgent start PD is that it avoids the tunneled catheter, and it's very cost effective. There have been small center non-randomized studies demonstrating the safety and feasibility of urgent start PD as an option for late referred patients presenting without a plan for dialysis modality. These are some of the protocols that we have and what I personally do for urgent start PD, which is you must have a way to get the PD catheter. I try to give them a bowel prep so that there are no hindrances once they start PD, the pre-op antibiotics. In order to minimize leaks, we do purse string sutures and fibrin glue. The fibrin glue data is from pediatric literature. And everybody tries to do low volume supine cycloperitoneal dialysis in some form. These are various strategies in which you could have inpatient initiation or outpatient initiation. As you can see, there is a lot of variability in who is the surgeon, that is, who is the operator that is placing the PD catheter. Could be a surgeon, interventional radiology, nephrology, or vascular surgery. Dwell volume is low depending on male, female, body surface area. Goes from 500 to 750 to 1000, and the frequency in hours is variable depending on how uremic or volume overloaded the patient is. Switching gears, talking about expanding the care to the elderly. We must think outside the box and think of ways of getting away from the in-center model. Assist PD is being used a lot in the vulnerable groups, that is nursing homes, in Canada and France with very good outcomes. It's not yet reimbursed in America, but the costs are mainly borne by family members. And there is respite PD, which is far more which means it's basically supportive therapy at home prior to transitioning to hospice. But respite PD can also happen in case somebody gets trauma, they get a fracture of the wrist, or they are advanced palliative care as supportive therapy at home before they go to hospice, surveillance of weakness or neurological problems. So respite PD is also something to consider in the COVID-19 era. Before we switch gears, I wanted to talk a little bit about telemedicine and home dialysis. We all know CMS has waivers in place for using telehealth in home dialysis patients, where there is relief from the requirement of initial 3-month face-to-face MCP visit post home dialysis initiation, the face-to-face MCP visit once every 3 months, and the question remains whether these waivers will stay in place after the crisis is over. Advantages of telemedicine are cost-effective, lesser hospitalization, better access. You can reach patients from different states. Problems with heavily lack outcome data. There are privacy concerns, HIPAA concerns, EMR integration. So this was my section on COVID-19, and I'm going to switch gears, but before we do that, we have another poll question. So the poll question is, what strategies have been used by your practice or organization to remodel dialysis delivery to improve home dialysis uptake? This is great. So it sounds like the comprehensive educational program wins, and still there is remodeling. And with transitional start being 19, I'm very impressed with that. And graded self-care 6%. That's very, very good. So let's move on to remodeling dialysis delivery and what we have been doing. All right, let me move. So we want to get novel infrastructure to empower patients to find modality based on personal goals. And transitional start units, in our experience, or a graded self-care unit, has been able to provide patients with expedited, repetitive education about different modalities of treatment, as well as improving their familiarity with home hemodialysis machines, prescriptions. We have developed a curriculum, as you can see, predominantly for motivated incident dialysis patients, and they undergo a very structured curriculum where they learn about access, modality, nutrition, clinical trial options, financial support, and transplant support. And after the 4th week, they graduate and they go into some form of modality or the other. It is important to be open-minded and develop personal goals with the patient. We also visited the patient very frequently. We didn't rotate doctors. We kept the same doctor and nurse practitioner to see the patient over and over again in order to smoothly transition them to home dialysis, in-center, or peritoneal dialysis, or transplant based on what they wanted. So who was eligible? I'm sorry. Who was eligible was all incident patients not already settled on home dialysis therapies, and we ruled out patients who were in long-term care facilities or hospice or who didn't have a stable living condition. These are some of our preliminary outcome data from the transitional start unit, where in an 18-month period, in a 1-year period, as you can see, 33% chose home dialysis modalities, and 20% were of all, those were 20% of all the new starts. The breakup is over here, and this is a work in progress, and we have been constantly feeding into the transitional start unit from our acute units so that patients can align themselves with their personal goals. Now we're switching gears to self-care, graded self-care pod. This was a little spin-off from the transitional start unit where we tried to create a graded self-care pod, but before we do that, why would you need a graded self-care pod? It empowers patients, especially a motivated patient, to have more control over their health in their own hands. Um, with an in-center self-care hemodialysis units, patients are trained to perform their own hemodialysis as if they were selecting a home hemodialysis modality in clinic with minimal staff support. Staff may assist with access cannulation, key barrier for home hemodialysis uptake, but typically the patients take full responsibility for machine setup, takedown, as well as majority of the monitoring and management during the course of the session. We insourced our hemodialysis care to the patient himself or herself, which allowed the facility to reduce the number of on-site staff and reduce the costs. There are several advantages of an in-center self-care hemodialysis place, such as a supportive, which will also give you the advantages of a home hemodialysis setup. And in other chronic diseases, patient engagement and empowerment has been linked with enhanced survival and fewer untoward complications. It cultivates a curiosity amongst all the patients about self-care dialysis. The way we set up this pod was it was in a circle, and only one quadrant was self-care and the rest was traditional care, so that there is inquisitiveness amongst the other patients regarding what one quadrant was doing, and they would ask questions and would want to get involved in self-care too. So there is a little bit of um, visibility of self-care to the traditional patients, and we should do that even for home dialysis training. So we sometimes use the isolation room in the home dialysis training to show that we are training somebody on PD, which creates curiosity amongst the traditional incident patients. And self-care graded pod is a viable option for respite patients who were on home hemodialysis and were getting burnout or were having caregiver burnout, or for a transition patient who is coming to visit and wants to try self-care. Are patients even interested in doing self-care? This was a survey done by Dr. Shertao, and there are other appealing factors for patients about flexibility in their treatment schedule, health benefits, their mood was better, they were able to immediately solve their problems, not having to wait to start and come off dialysis. And what really helped was an attitude of positivity from the nephrologist and staff in inculcating interest in self-care. What were the top 3 reasons somebody did not pursue home dialysis, home hemodialysis? You can see that home too small is now not a barrier to do in-center self-care. These concerns are not a barrier for in-center self-care unit and may allow patients for broader socioeconomic background to choose the therapy and not to benefit from the improved outcomes that it can offer. And you can see the top reasons why someone is saying that they did not choose home hemodialysis was uh, that not enough space at home for equipment and supplies. This is back in the day. This is data which is really old, but I wanted to say this is not new. Self-care dialysis used to happen in America in 1970s. Uh, there are these two papers from 1970s, 1980s, where you can see that time it used to be called in-center self-care hemodialysis, in-center conventional assisted hemodialysis, and an assigned home hemodialysis. And you can see the difference in outcomes that they had. But of course, keep in mind, this is before bicarb and before ultrafiltration controls. And patients who were doing in-center self-care had better outcomes. And if they had assisted hemodialysis, their outcomes were not so good. In 1980, there was self-care dialysis with extremely low rates of mortality and extremely high rates of rehab. Over here, I have tried to show some metrics of how home hemodialysis uptake was happening in 1970s to 1980s. America was doing very, very well until the end of 1980s. You know, the percentage of patients from 35% dropped to 23%. So this is very, very early on where self-care and home dialysis was very doable in America. So what is more recent? More recent data that we have is from from Dr. Jones, which is in the clinical outcomes of in-center self-care were compared to conventional hemodialysis patients, which were treated within the same provider network, within the same geographic area, using propensity score methodology. And you can see that the data showed that in-center self-care patients had fewer hospitalizations, they had fewer missed treatments, and they also had a lower mortality. Patients were well matched at baseline for age, sex, KTORV, lab data. The follow-up was 12 months, the median follow-up was 14 months, and one has to exercise caution with causal inference from observational data because somebody who's doing self-care is a less vulnerable group. And anyone who does self-care will probably have better outcomes because they may be a less sicker patient or a less complex patient or more engaged. So this is the data that we have so far, and but we have to take that with the grain of salt about outcomes regarding self-care. Next slide is the clinical considerations that we had. We used inclusion of improving self-confidence amongst patients, patients interested in having more control over dialysis, anyone who was involved in their prescription, interested in home therapies, or was a respite patient, we would bring them into our self-care pod. We excluded people from cognitive and learning disabilities, difficulties, physical strength limitations, and lack of interest. This was our graded self-care pod and the training phase. Like I said, there was 25% of the quadrant was self-care and the rest was traditional. And you can see that we nurses did a very good job of having a weekly graded step-up fashion of how they would learn self-care. And you can see on week 1, they were doing all these tasks of cleaning the access, obtaining weights, gathering supplies, documenting in the flow sheet. And you can see by week 5, they were able to perform all cleaning, disinfection, and cleaning the station. The main thing, the key barrier that you find and what we found in self-care is, again, access cannulation. Most people are there is this fear to cannulation of the access, and it is important to keep working with the patient with a positive outcome, positive outlook, have other patients talk to them to overcome those fears. I've tried to compare what a graded self-care hemodialysis unit does compared to a traditional in-center hemodialysis unit. Patients in the graded self-care hemodialysis unit are very motivated. They're involved in their care. They have stable comorbid conditions. Patients in the traditional ones are usually more vulnerable. They have a heavy burden of comorbid conditions, high complexity. The one in graded is seeking independence, autonomy. the ones who are interested in home hemodialysis are looking at it as a bridge, or somebody who's doing respite, as opposed to traditional who is liking assistance and is willing to follow a rigid schedule. In terms of physicians in the graded self-care hemodialysis pod are adopting an innovative mindset. There may be issues with varying level of comfort with different self-care modalities, but the physicians will have to get acquainted and learn about PD, home hemodialysis, different options, machines, and just be comfortable. Traditional, everyone is very comfortable with the traditional model of doing in-center hemodialysis. The next slide, I've tried to compare what are the differences for nurses. Graded self-care pod is lesser nurse or technician to patient ratio. You can alleviate your nurses and technicians. It improves their efficiency as opposed to a traditional pod where you would have, which would be more human resource intensive. But the advantage is if you have a self-care pod, you will be able to give more attention to the sicker and the complex patients. There are differences in the water system. You can have pre-mixed sterile batched dialysate. These are home hemodialysis machines out there. Production of an ultra-pure dialysate using reverse osmosis and deionization in small tanks, or sorbent regeneration of dialysate. So machines that make their own dialysate through the tap water, they're all there, and we must keep that in mind, because if you were to compare that to a traditional in-center dialysis water treatment, they use standard portable reverse osmosis systems with large amounts of municipality water. Further, if you were to compare certain outcomes, on the left-hand side, I have written what Dr. Shartow had in his in-center self-care hemodialysis delivery system, which which was designed to minimize training times towards home hemodialysis, make in-center self-care hemodialysis more appealing to a broader number of patients, reduce dropout, optimize reimbursement, and require fewer staff to support patients during therapy. According to Dr. Shartow, overall an economic advantage for the healthcare system providers and patients. In our anecdotal single-center experience, we've required fewer staff to support patients during therapy. We had our first home hemodialysis patient trained only in 2 weeks. Part of his training had already begun in the self-care pod. We've reduced hospitalizations, shortened and missed treatments, no mortality so far, and it's only 18 months worth of follow-up. We need to collaborate, of course, with other self-care centers to increase our numbers and derive more meaningful outcomes, because single center, a small number of patients is not going to give us meaningful outcomes. Like I said, a self-care patient who's more engaged can do well because of the fact that they are more engaged. It doesn't have to be the fact that they're doing self-care dialysis. So is empowered dialysis the key to better outcomes? So this was a very nice paper in NEGM Catalyst, and according to Dr. Gibney, which is 423 patients in their single center in Texas, the mortality rate amongst that group was 5.6% compared to 15.9% in patients undergoing conventional hemodialysis. And he said that self-care patients enjoy far lower mortality and hospitalization rates and far better attitudes about treatment, but there are hard limits to its adoption. So some advantages or incentives that self-care could have is to the patient, empowerment and control of their health in their own hand. Flexible scheduling. It unburdens the patient's caregiver to address caregiver fatigue. It's a viable option for patients whose home environments are not suitable for home therapies or are transient patients and would like to still have control over their dialysis. Motivated compliance with lesser missed and shortened treatments and hospitalization is possible. To a dialysis provider, it is less human resource intensive, increased efficiency of the nurses and staff, decreased wait time to home hemodialysis training and potential to increase home hemodialysis uptake. It's an affordable, high quality care, approximately 20 to 30% lesser cost. The facility prospective payment system is unclear. There is a reimbursement for training and to the doctor, but I don't think the self-care part itself is reimbursed. With the different payment models, the optional AAKH optional model, there is potential to improve patient activation measures in the quality gateway, where you could track the patient engagement scores over 6 to 12 months on a 9-question scale, which would influence your practice-based adjustment. And for the physician, there is, incentive because of bridge to hemodialysis, and physician fee for home dialysis therapies has changed, which all of you are well versed with. But with self-care, it is yet to be determined. So with that, I'm going to switch gears, but before we do that, another poll question. I think we're okay on time. We have 10 minutes. What has been the rate limiting step in home hemodialysis uptake in your practice? Well, this is quite expected, was the fear of cannulation of the access, and people are still voting, but that seems to be the winner. We all know the outcome data about home hemodialysis, but it's very, very difficult to overcome some psychosocial barriers of patients. So thank you for participating in the poll. And I would agree that I concur with everyone that fear of cannulation is definitely been our experience as well. Here, this is USRDS data. As you can see, that uptake of peritoneal dialysis continues to be the dominant form of home dialysis, and home hemodialysis is lagging. It is really down there, with only 4% of incident patients receiving dialysis in 2017. Um, uh, we have to address, and I'm going to spend the last 10 minutes talking about the challenges of recruitment in home hemodialysis. It's the low level of recognition amongst dialysis patients about the modality. There could be lack of self-confidence, lack of self-efficacy to manage your own therapy. Preconceived notion, it's too complex, too difficult. They don't have family support or social support, or they're fearful of machine or cannulation of blood access and worries about the catastrophic effect because it is their lifeline in their hands. Very tough, but education and understanding the patient perspective is the key. Pre-end-stage renal disease education class, in case they haven't heard about these modalities. Trying to teach them about different home hemodialysis modalities in the TSU or a graded self-care program if they are abrupt starts. Having a positive outlook by everyone in the dialysis team towards home hemodialysis uptake is very important. What really works with the fear of the machine and access is having another patient talk to them, or having the patient go and see someone doing home dialysis in their own house. Usually it is the peer, the good mentor that can actually allay a lot of that fear and anxiety, but it is very difficult to do behavioral changes in patients. Those are my solutions for these set of problems. But what about education gaps about home dialysis therapies or late education of patients? We must have those comprehensive education programs where there is early, repeated education about different options facing renal failure to allow patients to make an informed decision. The value and the timing of communication is very important. It's an integral part of the training curriculum. This involves nephrology training curriculum. or training of physicians through these webinars or um, in-person workshops that can happen in national meetings, all that needs to happen. And then there is improved physician willingness to adopt these therapies. And I'm pretty sure everyone is more than willing to grow home dialysis and refer to transplant. Other challenges, and these are real challenges, are maladaptation, non-adherence, family caregiver fatigue, and burnout. It's not easy to be isolated at home. It is not easy for the family to always be there. So, whenever there is non adherence or maladaptation, I try to isolate the problem from the patient. The patient is not non adherent, there is some problem that is making the patient non adherent. It could be anything. It could be mood, it could be substance, it could be social issues at home. We must try to address the problem while also addressing uh, other ways to cope with stress with intermittent retraining, review of technique, and regular telephone calls by nurses or clinical staff. And the social worker is of immense help in situations like this because they can do a weekly phone call check with the patient and make sure everything is going okay. We must have a continuous vigilance program, which is required with both the patient and the partner to understand problems, both current and the future. Respite care is something we can do for the self care pod, and a continuous quality improvement strategy needs to be there in every dialysis unit to address these issues. Before we summarize, I wanted to talk a little bit about transitions between home dialysis modalities. Whenever somebody is failing a home dialysis technique, or whether it's PD or home hemodialysis, we switch them to in-center. I would like people to do switches from home to home, which is PD to self-care in-center, if at all possible, which maintains control, flexible scheduling, maintains independence. And if this is a PD patient, they should have a secondary access in place so that they can switch to home hemodialysis if at all a switch has to happen. This is data on the right-hand side, which talks about the good outcomes related to home transition. Since we are running short of time, I'm going to summarize and I'm going to try to take questions because I'm sorry, I thought I would have 15 minutes, but I want to give everyone some time. So to summarize, this is educating patient about choices is the key in home dialysis uptake. We need to stop obsessing about which dialysis modality will give the longest duration of survival. Instead, we need to focus on what is important to the patient. An urgent start program is very feasible. It obviates the need for a tunneled catheter. Consider expanding the care to elderly with assist PD. Remodel home dialysis delivery with telemedicine, graded self-start units, transitional start units, or anything that you can think outside the box. Um, a home-first philosophy will help grow your home program, and transitions, if at all, should be made between home to home. That is the summary, but I would really like to thank UVA leadership, as well as my dedicated team, our Chief Medical Officer, Dr. Bowman, Debbie Cody, our Chief Administrator, Nurse Manager of Stanton Dialysis, Ms. Stever, Chris Clunan, the Biomed team, and my very dedicated team of Dr. Purav Shah, Ms. Brenda Burns, Ms. Fitzgerald, Ms. Jones, Ms. Peters, my nurse practitioners, Leah and Nina, and the biomed team, Anthony, and all the nurses and staff who actually make this a success. These things are not easy to do, and yeah, your teamwork is probably very important because the team is stronger than an individual. So thank you for listening to me, and I think I have say 5 to 6 minutes, and I sorry I ran a little over.
No, you're fine, Dr. Chopra. Thank you so much. That's great information that you presented. And actually, we just have one question. So if there are some other questions that anyone has, please take a minute to put them in the chat box. So the first question is, how much of the mortality advantage do you think is due to selection bias?
Yes, exactly. There is going to be a selection bias in small center, single center studies, and that's why I said we have to carefully assess the inference from studies about mortality. So outcome data is definitely um, with a grain of salt. Needs to be assessed, and we need larger studies with controls, with traditional in-center dialysis patients to um, assess, to balance these confounding factors. There is a selection bias because it is a less vulnerable group, and the fact that they are a less vulnerable group themselves will probably have good outcomes.
Okay. Another question that came through is, how do we implement self-care hemodialysis? Will DaVita, Fresenius, Renal Care, etc. allow us to do this?
Well, like I said, organizational priorities set the tone of what can happen. If my if the goal, so what is important is to set goals with the self-care unit. What are we trying to achieve? Um, the goal is to grow home hemodialysis. The goal is to improve patient engagement. The goal is to allow more autonomy to the patient, be more patient-centric. Um, that is how you would have to pitch to the organizations to get buy-in from the large dialysis organizations, and there is a good chance that they would be amenable to providing a self-care pod.
Okay. The next question, are the CMS guidelines for staffing of a self-care unit the same as traditional?
Well, that's a good question. I'll have to go back and read the CMS guidelines. I mean, I'm not usually in charge of allocation of nurses and technicians. I don't know about CMS guidelines, but in the self-care pod, we had lesser nurse to patient ratio compared to the traditional pod. But I will have to check those guidelines.
Okay. Let me have another one here. I heard you say you trained your first home hemodialysis patient in only 2 weeks. Which device did you use?
We used tableaus with the Outset Medical. Um, they were being used in our self-care pod, and that was the device that was chosen by the patient.
Mhm. And then I have another question that says, do they use the regular chairs? That's all they said for the
Yes,
question.
yes, it's a regular, the regular traditional hemodialysis chair. The machines are up to them. They can choose the machine that they want.
Okay. All right. I don't see any other questions come through. I'll give everyone one more second if you had another question for Dr. Chopra. Okay. If that is all, again, Dr. Chopra, thank you so much for this presentation. Again, a recording of this webinar will be on the RP website in our e-learning portal. And we'd like to thank everyone for participating today. This is a CME webinar, and nursing education credits are available. So I will be sending you an email on how to claim those credits. So please be on the lookout for that, along with an evaluation. So I'd like to thank everyone for joining us, and have a great day. Be safe and stay well.
Thank you, everyone, for your
Thank
time.
you,
And
Dr. Chopra.
yes, thank you, RPA.